Yeah. Okay. So we are the first I will mention about some pharmacokinetic models. As you know, there is one compartment model, two compartment model, yeah, multi-compartment and non-compartment. Yeah. Let me just so we have one compartment model, two compartment and multi-compartment and non-compartment, yeah, non-compartmental. Okay, non-compartmental model. So what is this one compartment, etc., etc. here? So one compartment model, yeah. So the blood vessel, this is blood vessel, yeah, are considered to be a big container. Can you imagine a big container? Yeah. So although we have a lot of blood vessels, but all our blood vessels are connected, isn't it? Yeah. The artery, the vein, yeah, are all connected. So these blood vessels are considered as a big container. And a substance that enter into the blood vessel will increase, yeah, if there is an absorption or administration through IV, yeah, and it decreases where there is elimination. So this one understandable, yeah. Okay,
Okay.
so this is the simplest concept, yeah, that one compartment is the simplest concept. So our blood is like one compartment, yeah, one container like that, yeah. Later on, there is an implication for that. Yeah. So the one compartmental model, yeah. For example, this is IV bolus. Yeah. So the graph of concentration and time, yeah, concentration and time. Okay. In the IV bolus model, this is IV bolus model. Yeah. If we plot this graph on the normal graph paper, and it is not on in, yeah, but on, yeah. If we plotted on normal graph paper, uh, one compartment model. Okay. So if we plot it in one a normal graph paper, it will be like this. Yeah. So if we plot in the semi-log graph paper, this is semi-log. Why we call it semi-log? Because this one is logarithmic, yeah, and this one is normal, yeah. So because one side is normal, another side is logarithmic, so it will be called semi-log. Understand? Yeah. So the semi logarithmic graph paper, it increases like 0 and then 1 and then 10 and then 100 and then 1000. Yeah, because the scale is 1 2 3, but 1 for log is 10, right? 2 for log is 100. 3 for log is 1000. Correct or not? Yeah. So it follows that, okay? But for the normal graph paper, it will result in this. So this one, if in mathematics, we know this is called exponential, yeah? Exponential. Now, so whereas for two compartment model, so our body is considered, so when drug is administered, it is administered to the blood vessel, correct or not? Yeah. So when the drug is taken by oral, so when the drug is being absorbed, so it will go to the blood vessel. Yeah. So the blood vessel is our central compartment. Okay. So from the blood vessel, this drug will be distributed to the peripheral compartment. Yeah, so we have now two compartments. One is the blood vessel. From the blood vessel, it has to be distributed to the tissue. Yeah, so the tissue is the peripheral compartment. Understand? So when we have calculation, we have to calculate both the central and peripheral. Yeah, so the two compartment model is a little bit more complicated. Yeah, the one compartment is the simplest one. Okay, But the two compartment model is more what do you call actually most of the drug will follow two compartment model, yeah, because the drug will go to the tissue, because it is in the tissue that we need the drug, correct or not? Yeah, so actually most of the drug follow two compartments, but it is more difficult to calculate, yeah. So for TDM we use a lot of one compartment instead of two compartment, yeah. So this is the graph for two compartment model, yeah, two compartment. So what will happen, so when the drug first time, yeah, the drug will be distributed, right? But when the drug is distributed, the drug at the same time also eliminated, correct or not? Yeah. So for you can you imagine now the drug is being absorbed, yeah, from the gut to the blood, right? But at the same time, when the absorption is still going on, yeah, and the drug from blood is distributed to the tissue, yeah. But at the same time, also there is the drug also being eliminated by the kidney. So it doesn't wait. Yeah, it doesn't okay, now distribute first lah. After finish distribute, then only we eliminate. No, right? So it is concurrently, minute to minute, concurrently. Yeah. In this phase, there is a distribution. Yeah, to the peripheral. Yeah, to the tissue. But at the same time, there is also elimination, yeah, going on, yeah. So here SDO is a mix between the distribution and elimination, yeah. Now, but the drug when the distribute, yeah, it is um in the equilibrium, yeah. The from the central go to peripheral, from the peripheral go to central, yeah. So it is on equilibrium, yeah. So after finish, at first there will be more in the central, right? So it will be distributed to peripheral, yeah, and distributed back a little bit. So until, yeah, such that the central almost finished, yeah, everything is distributed to peripheral, yeah. So it depends on the k here, because the k is not the same, yeah. So normally the k21 is more, yeah, so distributed. All right, so here and the drug will be eliminated, yeah. So this one distributed at the same time it is eliminated. So this door is open here, the door is open here, yeah. So at the same time it will be eliminated as well, yeah. So if we go to this graph, so it is distribution. So this is mainly why the graph is steeper here, is more steep, yeah, more steep or steeper here, because that time there is a lot of distribution, because this is concentration in the plasma, yeah. So the plasma concentration quickly decrease because there's a distribution to the peripheral. At the same time there is an elimination, yeah. So both elimination and distribution happen together, okay. Now until here the distribution slow down already, yeah, and then the distribution almost finished, and from here to here it's only elimination. Sorry. Yeah, so the distribution almost nothing, yeah. So here is what we call post-distribution phase, yeah. Now, sometimes we also call it as elimination phase, because in the here, it is mostly elimination. Understand? Yeah. So, one of the drug that follow two compartment, yeah, it is, for example, vancomycin. Yeah, vancomycin follow two compartments. Yeah, it follows linear, not non-linear. It is linear. Yeah, but two compartments. Yeah. So what will happen when we inject the vancomycin? Yeah. So we infuse the vancomycin being infused. Yeah, infused. Let's say we infuse over 1 hour or 2 hours, yeah. So once we infuse, so the drug go to the blood vessel and then it will be distributed, yeah. For vancomycin the distribution is quite fast, it's around 1 to 2 hours, yeah. So 1 to 2 hours it will be in distribution phase, yeah. Then from there it will go to the elimination phase. Now in the distribution phase, when we have got the formula, the equation, the formula is very long because there is a Ka there, Ke there. Yeah, so there are two. There's Ka, K at no, it means there's alpha and beta. Sorry, yeah, alpha and beta. Alpha for the distribution, beta for the elimination. Yeah, so it is very messy. Yeah, if it is here, if we straight away calculate the concentration here, yeah, it is very messy. Yeah, so for most of the time, yeah, we will wait until it goes to elimination. Yeah, until it goes to the elimination. So we only follow the one we follow only one compartment model. Yeah, because here we can follow only one compartment model because already only elimination. Yeah, and we can calculate the only we need the Ke, not Ke. So Ke or beta, yeah, beta or Ke is the same. Yeah, so we only follow we only need the beta, not the alpha. So it's simpler. So that's why our application of this, yeah. So for vancomycin, we need to wait, yeah, for 2 hours after finish of the infusion. Yeah. So after finish infusion, we still wait for 2 hours to get the peak concentration. Yeah, 2 hours after infusion. Remember. Yeah. So that is the two compartments. Do you have any question here?
No.
So this is also on normal graph paper, and this is on the semi-log, yeah, semi-log graph paper. Okay, semi-log, you can see this and this. Yeah. All right. No question, we can go on. Yeah. So this is three compartments. Yeah. So three compartment is even more complex. Yeah. Complicated. So you have the central compartment, then go to the peripheral compartment and small peripheral compartment. Yeah, and there is also elimination. Yeah, so it is more complex. Okay. And also there is also non-compartment model. Non-compartment model, the assumption is that all medicines and their metabolites follow the first order kinetic. Yeah, and the use of AUC. So you heard about AUC, yeah, area under the curve, yeah, to measure the exposure of medicine in the plasma. So it's an example of non-compartment model, yeah, the AUC. Now, from first order kinetic, yeah, first order kinetic or linear kinetic. So it's the same, yeah. First order and linear is the same, okay? So linear kinetic, the changes of concentration and time is proportional, okay? Linear kinetic follows the first order kinetic mathematical model. Yeah, most of the medicines for TDM follow this model. Yeah, so if you see this one, for example, we administer 1000 milligram, 1000 milligram. Okay, then it was at eliminated 100, so you have still have 900, right? So what is the fraction being eliminated? 0.1, yeah, and 0.1, yeah, so 0.1. Now from there, yeah, and then you have got then from here 100, yeah, 0.1, then another 0.1 fraction being eliminated. So from 900, 10%, 10% is 90, yeah. So from 90, so now balance is 810, okay, and 0.1 or 10%, yeah. So always 10% being eliminated, and this one is depends on the drug, yeah. The drug, for example, 100, 90, 90, 81, because 81 is 10% from here, yeah, and 10% from here 73, 10% from here 66, 10% from here 59, yeah. So this one is how it will be for the first order kinetic. Yeah. So the fraction, okay, I think I have to change this because this one is in bahasa. Okay, so the fraction that eliminated, yeah, yeah, I will change this one later on. Yeah, don't worry. I didn't realize that this is in bahasa. Yeah, so the fraction is the same. Yeah, but so the amount of drug being eliminated is different. Yeah. Okay, so the first order kinetic, when it is in the normal linear scale like this, and this is in semi-logarithmic scale. Yeah, this one I already explained. Now, calculation of the first order kinetic. Yeah, so follow. Yeah, this one. Okay, A. Yeah, equal to A times E mean KT. Yeah, so this one is first order kinetic. Yeah, and if we put it in the ln, yeah, we integrate this, become ln A equal to ln A0 mean KT. Yeah, so that one you have to know lah. Yeah. Okay. And then now non-linear kinetic. What is non-linear kinetic? Yeah. Some medicines follow the non-linear kinetic model. The most common example is phenytoin. Okay. Non-linear kinetic follows the model of zero order kinetic. In this model, the amount of substance increase and decrease is constant, but the proportion differs. I will show you in the table. Yeah. Among the various reasons of nonlinear kinetic is the saturation of enzymes for metabolism. Just now my question to you, what causes the nonlinear? Yeah, most of the cause is because of the saturation of enzyme. Yeah. When the dose of the medicine is higher than the maximum capacity of the enzyme, the amount being eliminated will be constant. Yeah, therefore there can be accumulation of the medicine. So just now Dia mentioned that the non-linear increase in small amount of dose drug, it can cause increase in a high increase in concentration. Yeah, because of why? Because of the capacity, maximum capacity of the metabolism, for example, in case of phenytoin. Yeah. Okay. Another reason is the saturation of the another reason, another meaning that beside metabolism, there is also saturation of transport protein molecule for absorption. Yeah. So you just to remind you, for example, like for absorption, yeah, the drug must go through the membrane, yeah, membrane of the intestine. Correct or not? Yeah. So what kind of drug molecule that can cross the intestine? It is the polar or non-polar? The polar one or the non-polar one?
I only know the non-lipid soluble.
Yeah,
Lipid soluble is
yeah. So the lipid soluble or not lipid soluble?
non-lipid.
The lipid soluble, yeah. The lipid soluble that is easier to cross because our cell membrane is lipid bilayer. Yeah, so lipid is more soluble to lipid. So the lipid one can cross the membrane easier. Yeah, but then the aqueous or the polar lipid is non-polar. Yeah, the polar one, yeah, the water soluble one is it's more difficult to be absorbed. Yeah, so in order for that, they need some carrier protein. Yeah, carrier protein. Yeah, carrier protein. So this carrier protein can be saturated, meaning that they can have a certain amount of carrier protein. Yeah, so if you have got a huge dose of drug, yeah, and it not all can be absorbed at the same time because the carrier protein is not available. Is not available for all the dose. Yeah, so it takes time. So the absorption becomes slower when you have more dose, more amount of drug. Yeah, So this is what happened to non-linear. Yeah, so the non-linear one take longer time. Understand or not?
Yeah.
Is it more clear now for you? Is it clearer? Yeah. So if you want theoretically, yeah, these are the causes of non-linear model. Yeah. For example, saturable. This is for GI absorption. Yeah. Saturable transport in gut wall. Just now I mentioned about that. Yeah. Intestinal metabolism, because there's also metabolism, small amount of metabolism in the intestine. Yeah. Can drug with low solubility in GI, yeah, saturable gastric decomposition, okay, and distribution as well. When you have the distribution, so you have, for example, like tissue binding, yeah, saturation plasma protein binding, because the drug will bind to protein, yeah. So if you bind to protein, okay, so it will be less being eliminated, for example, because it bound to protein, yeah, and it depends on the protein, albumin and protein in your blood, okay, and transport into and out of tissue, yeah, and then but the most important is metabolism in the liver, like phenytoin is because of saturable metabolism, yeah. But there also renal elimination, yeah, like for example active secretion, tubular reabsorption, because this active secretion, it needs the carrier protein, yeah, so the carrier protein can be saturated, okay. Even the biliary, but the most important is saturable metabolism in the liver, yeah, metabolism. And this part understand or not?
Yes.
Yeah. So now, so non-linear kinetic again, yeah. So normally, because you remember in phenytoin there is a Km and Vm, Vm and Km. Remember or not? Yeah. So the,
Volume.
yeah, maximal Vm, yeah, maximal capacity of metabolism, Vm, yeah, Vmax, okay. So if the Vmax is high, it means that the maximum concentration, the maximum amount, yeah, that the drug can eliminate at one time is higher. So it means that the capacity to eliminate is higher, yeah. But if the VM is low, so the capacity is lower, so it can cause toxicity more, yeah. So Km is the concentration of drug, yeah, when the VM is at half, okay, when the VM is at half, so the Km is the concentration. So the higher the Km, it means the more the ability, yeah, for the drug to eliminate this, for the body to eliminate this drug, the more the higher the Km, yeah. Okay, so now what I want to explain by this graph is that this is the linear kinetic, yeah. So the linear kinetic, like what Dia said, it is more predictable. Let's say you have you have this dose, yeah, you can predict the constant steady state, yeah. And then you have, if you double the dose for the linear kinetic, yeah, if you double the dose, the concentration also will double, correct? Yeah. Let's say
Yeah.
if your dose here and your concentration is here, so if you double the dose, the concentration also will double, yeah. So that is the linear kinetic. But the non-linear kinetic, if you double the dose, yeah, wow, the concentration can be as high as 4 times, 5 times, yeah. So that's what Dia said, unpredictable, yeah. But actually you can predict by the graph, yeah, or by the formula, you can predict, yeah. But what she meant is actually it is not, it doesn't goes proportionately, yeah. This is what you want to say, Dia.
Yeah. Yes.
Yeah, not proportionately, yeah. You can't just figure out by, simple mathematics, you cannot, yeah. Whereas the linear, if the linear kinetic, even if you forget the pharmacokinetic formula, it's okay. You still can double up, you know, adjust the dose using the basic primary school mathematics. But for non-linear, cannot. Yeah, for non-linear, you have to know the formula and calculate it. Yeah. So, and then most of the drug, let's say we talk about phenytoin. Yeah. Now, phenytoin, yeah, the Vmax is quite low. Yeah, the Vmax is in the therapeutic dose. So the therapeutic dose of phenytoin is around 300 to 500 milligram per day, yeah, for adults. And so the Vmax is around that, around 400, yeah, for normal adults. So meaning that you have to be careful, because once when the drug is, if the amount of drug is low, you can see in this graph, yeah, when the dose is low, they actually follow the linear kinetic. Yeah, correct or not? Yeah. And once the dose is higher than the Vmax, yeah, so it will follow the non-linear kinetic. Yeah. So the drug will follow the non-linear kinetic, yeah, when it is approaching the Vmax. Yeah. When it is above the km. Yeah, above the km. Yeah, so it will eventually become the non-linear. Yeah, but we are not too sure when it will become non-linear. But um but that theoretically, yeah, if in the low dose they are linear, but a higher dose they become non-linear. Yeah, that one you can accept. Yeah, so if you see this graph, yeah, so it is, if it is low dose, yeah, it is linear. Okay, but if this higher dose, it become non-linear. Yeah. Now, just to compare between the zero order, this is zero order and first order. Yeah, we have mentioned about the first and zero order. I'm sorry about the bahasa. I will change it later to English. Yeah. So, but this is a good table, yeah, because you both start with 1,000, yeah, but this one is zero order. So zero order, you have got constant amount of substance to be eliminated, yeah, because this is the capacity of the enzyme, yeah. So if the capacity of the enzyme 100, whatever you have 1,000, you have 10,000, you have 100,000, you can only eliminate 100. Yeah. So this one is the degree is 100, 100, 100, 100. Yeah, so this one becomes 0 0.10, 0 0.11. Yeah, so the fraction keep increasing, because yeah, the drug keep, this one, the fraction keep increasing. Yeah. And then, but the first order is different. Yeah, the fraction is the same. Yeah, but this is different, the different in the amount of drug. Yeah, but the fraction is the same. Okay, now it looks like that if you use zero order, first order, yeah, it is less, it's slower to get rid of the drug, right? Because from 1,000 to 531 is until the sixth time. Yeah, this one is until the sixth time, it's already go down to 400. Yeah, but don't forget, this is because we give 100. Yeah, if we give different, for example, like if you give 10, yeah, so it will be longer, because 10, 1,000 to 10 is 990, then 10, so it's 9,800, like that. Yeah, so it will be very long, because it can only, capacity is 10, 10, 10. Yeah, whereas this one is 10%, because 10%, 10% is easier. Yeah, understand or not?
Yeah.
Yeah. So most important when we want to do the kinetic, yeah, we need to find the VD, KA, KE, clearance, CP, T half, area under curve. Yeah. So the next we will see all this. Yeah. Okay. So loading dose, maximum concentration. So this is the one I mentioned. that the one compartment, yeah, so our body is considered as one container, yeah. So if it is a big container like this, so we the whole is become the volume, right? So the CP or concentration, yeah, concentration is now the concentration is the dose divided by VD, correct? Yeah, the dose divide by VD, yeah, the concentration, yeah, this one, yeah, the dose divide by VD, yeah, the smaller the VD, the higher the concentration, yeah, the higher the VD, the smaller the concentration. Okay, yeah, example, loading dose 10 milligram. So this is the application is for the loading dose, yeah. When we give loading dose, it means that we load, yeah, we load at one go, yeah, the patient, yeah, with this amount, yeah. Let's say, so they said that we want to achieve target concentration of 10 milligram per liter, yeah. How much of loading dose needed, yeah. So we just calculate this one times the VD, yeah. Concentration times VD is the dose, because dose just now, dose concentration is dose divided by VD. So if we want the dose, then concentration times VD, yeah. So this is the application. Until just now, okay or not? Here, clear?
Yes, sir. Yeah.
Yeah,
Okay.
this is the easiest, yeah. So now next is clearance, maintenance, dosing rate, and AUC. Yeah. So this one is drug concentration. Okay. Now, at the steady state, yeah, maintenance dose rate in administered in and out is the same. Do you all hear the noises or not?
Yeah.
You all hear the noises from the TV, yeah?
Yeah.
Yeah.
But it's okay. It's okay.
Okay, so I will close the door because the children are watching TV. I close the door, yeah. All right. Okay, so at the steady state, the maintenance dose rate in and excretion rate out is the same, yeah. So infusion rate. So infusion rate means that the amount that we give per time, yeah, the time can be hour, like this one milligram per hour, yeah, is the same as is equal to concentration the times clearance, yeah. Infusion rate is equal to concentration times clearance, yeah. Yeah, because clearance is actually the amount of, see, yeah, clearance is liter per hour. It means that the amount cleared, yeah, cleared per time, okay. And then this milligram per liter, yeah. So this is the thing that go out, yeah, because this one is the amount go out, yeah, because if your liter and liter you cancel it out, yeah, so it's milligram per hour, correct or not? Yeah, milligram per hour. So this one is milligram per hour, right? So the rate going out is this one, yeah. Same with the rate going in. Yeah, understand now?
Yes.
Yeah. So now for constant rate infusion, continuous infusion, yeah. Now infusion rate using this just now, yeah, is the same as CSS concentration in the steady state times clearance. yeah, divide by S. S is what? S is a salt form. Yeah, salt form. Because some have salt like theophylline has the S, right? And 0.8, yeah, or 0.85 depends on the book. Okay. Uh, so some for most of the drug S is 1. Yeah. Now, but if we want to know the CSS, that is the concentration, so it is infusion rate divided by clearance. Yeah, IR, infusion rate divided by clearance. Yeah, that is the CSS. Nah, CSS, yeah, infusion rate divided by clearance. Okay, and if we want to know the clearance, then it is the infusion rate divided by CSS. Understand this one? So as I said, the continuous infusion is the easiest model. Yeah. Beside bolus lah. Bolus is the easiest. Second easiest is continuous infusion. Nah, this one is oral administration. Yeah. Oral administration multiple. This one multiple oral. Yeah. Multiple oral. So you have the steady state, average steady state. Yeah. And we have the CSS peak and CSS trough. Yeah. Just to mind that after the CSS, yeah, there is no more fluctuation. Yeah, so the peak and the trough will be almost the same after it reached the CSS. Yeah, whereas the CSS average actually you cannot use the C peak, yeah, plus C trough divide by 2. Cannot. Yeah, you cannot do that. Yeah, it doesn't work. It doesn't work that way. Yeah, C peak plus C trough divide by 2. Cannot. Yeah, it doesn't work that way. You have to calculate the CSS average using the previous equation, this equation. Yeah, all right. So the oral dose, yeah, CSS average. So this CSS average times clearance, yeah, divide by F and S. Yeah, F here is bioavailability, S is salt form, because oral has bioavailability. Yeah, so the bioavailability have to come into consideration. Whereas the IV, there is no bioavailability. IV is the bioavailability is 1. Yeah, so the bioavailability is 1 for IV. But for oral, bioavailability can vary. For example, like digoxin is around 60 to 70%. So here, understand or not?
Yes.
Yeah. So what is how to calculate the area under the curve? Yeah. Response may be related to overall exposure of a patient or the organism to a drug. Yeah. For example, anti-cancer chemotherapy, antibiotic. Yeah. Exposure means the amount of drug being exposed to that patient, yeah, depends on the dose administered, yeah, and the patient's ability to clear the dose. So the AUC is the amount exposed, yeah, is equal to daily dose divided by clearance. Yeah, daily dose divided by clearance. So it means that the more the dose, so the more the larger the AUC. Yeah, and the more it is cleared, so the smaller the AUC. Okay. So example, dose 400 milligram, clearance 2.5 liter per hour, and volume. So clearance can be liter per hour, can be ml per minute. Yeah, so you have to be careful when you have calculation. Careful about all these units. Yeah, must be the same. Okay. So this is the IV one. So AUC, so AUC is here. All the scarlet one is AUC. Yeah. See the dose divided by clearance. 400 divided by 2.5, 160. Yeah, so that is the AUC. Okay, loading dose. This one is our a bit of summary, but we still have a few slides to go. Yeah. So the loading dose equal to concentration time volume. Yeah. Okay, and then maintenance dose. dr stands for uh, um, uh, dosing rate. Yeah, dosing rate. Okay, because it is a milligram per hour. Yeah, dosing rate. Yeah, equal to CSS times clearance. AUC equal to F times dose because it's amount. Yeah, the dose, and divide by the dose equal to AUC times clearance. Yeah, AUC times clearance. Or maybe what we can do is a dose, yeah, equal to C what concentrations time V. Yeah, the dose is concentration times V. Correct or not? Concentration is dose divided by V. Yeah, correct. Yeah. So the dose is concentration times V. Dosing rate is CSS times clearance. Yeah. And FD, the dose is equal to AUC times clearance. Yeah. And AUC equal to dose divided by clearance. Okay. Now, when we talk about IV bolus now, yeah, IV bolus, we need a constant rate, elimination rate constant, yeah, K, all right? So K has units per hour. Okay, K depends on the clearance and the V, yeah, VD, the volume of distribution. Yeah, so our formula, yeah, clearance equal to VD times K. Yeah, clearance equal to VD times K. Sometimes it's quite, this is important, yeah, but sometimes we make mistake, yeah, how to memorize, yeah, maybe C clearance, yeah, CL. So it is alphabetically, it is the smallest, right? Clearance equal to V times K, yeah, the VD and K. Okay.
Okay.
Now, how to predict concentration at time t? Yeah. So when we do this one is single, yeah. So we have the single IV dose, single dose, yeah, one dose. So it will go down like this. Ching, go down, yeah. Remind me, is this on normal graph paper or on semi-log?
Normal.
Normal graph paper, yeah. So it follows exponential. This is E, yeah, mean KT. So when you have using the semi-log, it is following ln, yeah, or log, depends, yeah. So now you have the 2 hours, yeah, predict concentration at 2 hours. Okay, so this will be your because IV bolus is easiest is dose, yeah, concentration, dose divide by V, yeah. And at any time there's an elimination going on. So this is the factor eliminated, yeah, E power by minus KT, yeah, E minus KT. Okay, so it will be less, yeah, less after you have a T. The more the T, then the concentration will be lesser and lesser. Okay. So from the two, from if we have two concentration, let's say we do the peak and the trough. Yeah, this one is the peak and this one the trough. So we can get the K. Yeah, we can get the K. All right. So if we have two, yeah, we can put ln, right? Ln, and then we can get the K. Yeah. Okay, so from here you can get the K, yeah. Uh, now volume distribution. So volume distribution, we just apply the formula, yeah, just now because E minus KT. So we know already the K and the T is 2 hours, yeah. Then we can get the VD because we know the dose and we know the concentration. Okay, so until here, understand?
So how about the half-life?
Half-life later, yeah. I hope there will be a half-life. So just now we get the D, the distribution, yeah. So if you want to get the clearance, remember clearance equal to VD times K, yeah. So now you have the clearance as well. Half-life, nah, now you ask for half-life, half-life comes. Yeah, half-life, time for concentration to fall to half, yeah, depends on clearance and volume distribution. So basically half-life is 0.693 divided by K. So what is the 0.693? That is ln 2, yeah, ln 2, yeah, because if you want half-life is actually concentration decreased by 2 times, yeah, half, yeah. So when we apply the equation here, this equation, you apply it, yeah, you apply this equation. So the half-life, yeah, like this one, yeah. So we apply it here. So we put, let's say here, because C2 and C1, yeah. So the C2 to C1 become 2, 0.5, yeah. This one is 0.125. If in half life, because it's go to the half, yeah. So here is 0.5, okay. No, 2 or 0.5.
0.25, is it?
No, what I mean is that, let's say you want to get the half life, yeah. So the half life concentration, for example, concentration of here at hour of 10, let's say, yeah, this hour. So here is half of here, your half life, right? So concentration here is 0.5. This one is 1. So 0.5. So it will be 0.5 here, yeah. Anyhow, uh, because here it's difficult for me to so this is the formula to get the half-life, but 0.693 comes from ln 2, yeah. So if you allow me to write it, yeah, so I can show a proof for you, yeah. So in the first order, yeah, C2 equal to C1, yeah, times E min KT, yeah, min KT, yeah, ln C2 equal to ln C1 min KT. Okay, so your if you put KT that side, yeah, KT equal to what? Ln C1 uh, minus ln C2, yeah, correct? So K equal to ln C1 minus, you know that in ln, yeah, in logarithmic minus is divide, yeah, ln C2 divide by C2, okay, in the logarithmic sense. If you go to our mathematics class, yeah, divide by K, K, yeah, and this one is T, sorry. So T, yeah, T ln C1 divided by C2 divided by K. So if it is T half, yeah, T half means that the concentration fall, yeah. So let's say ln C1, let's say C1 2 milligram per liter and C2 is 1 because it become what we can half, correct? Yeah. If
Yeah.
we say 4, 4 to 2, 4 divided by 2 is 2. Yeah. So ln 2, yeah, ln 2 divided by K. Okay. Now, if you use calculator, ln 2, yeah, is equal to 0.693 divided by K. Yeah. So from where it comes from. Okay. This is the proof of this one. Yeah. Okay.
Yeah.
Yeah, very basic lah this one, yeah, very basic. Okay. Uh, okay. Now, we used to determine time to eliminate drug, time to reach steady state, and dosage interval. Yeah. So time to eliminate, yeah. So 50% is eliminated in, yeah. If we have 1 times half life, it means the 50% will be eliminated. Yeah. So second of the half life. So from 50% now become 25%. Yeah. So 50 plus 25, 75. Now 3 times of half life. Just now you have 77. You have to 25. 25 divided by 2 is 12.5. Yeah, so 87, 75 plus 12.5, 87.5. Yeah, being eliminated. And 4 time half-life 60, 94, and 5 time 97. Yeah, etc. Will it be 100% eliminated? Do you think?
No.
No, yeah, it will not, because this will become infinity. Yeah, maybe 90s, 99 point something, something, something. Yeah, it won't be 100%. Okay. Now, so similarly, yeah, for half life, for steady state, yeah, if you first given the dose, yeah, it will achieve. Let's say this one is typical of IV infusion. Yeah. So if you give infusion for 1 half life, it achieve 50% of steady state. Yeah. Second half life, you achieve 75%. Okay. And then third half life, you achieve. So how you know that achieve 50%, 75%, and all this? Yeah, it's actually the first half life, yeah, and the first dose you give. Okay. So 50% will be eliminated, right? Yeah. You give again. So from the 50% eliminated, yeah, 25% will stay. So the 50 time plus 25, then 75. Yeah. And just like the previous slides, until you achieve 5 times is 97%, yeah, of the half-life, of the steady state. Yeah. So now you achieve almost 100% of steady state after achieving 5 times half-life. Yeah. So normally we use 5 times half-life to know whether this patient has achieved steady state. Now I want to ask you a question. What is the important for us to know when it will achieve steady state? Why is it so important for us to know when it will achieve the steady state? What is the big deal of steady state?
Is it because steady state helps to know whether the drug is in the therapeutic range or no?
Yeah, one thing you can say that because all the therapeutic range is the steady state therapeutic range. Yeah. So so we need this. If you see the state, if you see the steady stage, what is the difference between the steady stage concentration and before the steady state?
The steady state, the concentration is at the maximum.
Yeah. So the steady state concentration is the word steady, right? So it doesn't change much. So it will be around this. Yeah. So it's stable, steady, stable. Yeah. So you need this to know what is actually the stable concentration of this drug. Yeah. Because say if you take the plasma concentration here, what will happen? Let's say you are giving a drug and then you before it reach the steady state, you already take the plasma concentration here. What will happen?
You treat like subtherapeutic.
Yeah, so you will think, oh, it's still very low, not yet therapeutic, yeah. So what you will recommend to
Increase dose.
Increase.
increase dose, yeah. But if it is not yet achieving steady state, will it deceive us?
No,
Huh? Is it safe at this time to increase the dose?
no.
No, why?
It can shoot higher to
Yeah,
reach toxicity.
yes, because it has not achieved steady state. Yeah, we consider it as already very low. Yeah, so we add up the dose. So what will happen if let's say the drug achieve the steady state, it can become higher, correct or not?
Yes.
Yeah, it probably here because we already add the dose. Yeah, it may probably here. Yeah, so we are impatient. Yeah, then it will be already here. Yeah, so you can understand now why it is important for us to know the steady state. Yeah. Okay, but one thing is there are so the steady state depends on half life. Yeah, so we want steady state 5 times half life. Yeah, do you know what is the half life of digoxin in normal renal function? Yeah, the half life of digoxin is around 30 hours, 30 to 35 hours. Yeah, so let's say you take 30 hours, 30 times 5, how many? 150. Yeah, 150 hours mean how many days? 24, 24, 24,
Five,
24, around
five,
5
6.
days. Yeah,
60.
6 days. So after 6 days only, it will achieve the steady state. Yeah, so will it be too late already? 6 days you have to ask the patient to be in the ward at least. Yeah. Now sometimes it is not so practical. Yeah. But we have to, because we need to know the steady state concentration. You cannot just simply. Yeah. Yeah. So in that case, yeah, if you get the concentration before the steady state, then you have to alert the doctor. Yeah, this is not steady state. Yeah, this is not a steady state concentration. So we can't use it to we we can take the non-steady state concentration, but it is only for us to know, yeah, whether it is toxic or not toxic. Yeah, for example, like you give the digoxin, yeah, probably a bit too high dose. Yeah, and then the patient show the symptoms of digoxin toxicity. So at that time, yeah, you don't have to wait until steady state. Yeah, you can straight away take the the level. Yeah, because you want to know this level now the patient is like toxic. Is it a toxic level or not? You want to confirm. Yeah, you don't have to wait for steady state. You only wait for steady state when you want to adjust the dose. But when you want to know the toxicity, you don't need to adjust. You don't need to wait for steady state. Yeah, you want to know the actual one now. Understand or not?
Yeah.
Yeah, I hope you are clear with this. Yeah, so now concentration time profile single constant rate infusion. Yeah, so this is what I said that constant rate infusion. Yeah, this is easier. Yeah, so the in the steady state it will be like this. Yeah, very short formula. But if before achieve steady state, then you have to add this. Yeah. So what is this? This is the what we call fraction achieving steady state. Yeah, because it is not yet achieved the steady state, but it is only a fraction achieving steady state. Yeah. So the fraction is always one minus something. Yeah, because one means already achieved steady state. Yeah, minus something. The something is the e power by mean k t infusion. Yeah, because before you achieve steady state, yeah, you infuse the t infusion here. All right. So at this point of time, I cannot prove all this formula. Yeah, actually, if I want, I can prove it. Yeah, but it is not for the. We don't have time for to prove formula for each
So
number.
the
Yeah,
TIN stands for infusion rate, is it?
yeah, T infusion. Yeah, T infusion. Yeah, different
Oh,
book get different. Yeah, you sometimes you use T accent, right?
uh-huh.
Yeah. So this one T infusion. This one is for continuous infusion. Later on, they got tau and all this, right? Yeah. So this one is intermittent infusion. You know what is intermittent infusion? Intermittent infusion means short infusion. Intermittent, yeah. So it means, let's say this drug is infused over 1 hour, yeah, over 1 hour. So then the infusion being stopped, yeah, being stopped. Okay, stop. So it will go down, yeah. So this is single dose in intermittent infusion, yeah. So the formula that we use is this one. Yeah, CT equal to CT means the the concentration at any time, any T. Yeah. So it will be S IR per clearance. This one is steady state. Yeah, and this one is fraction achieving steady state. Yeah, fraction achieving steady state. Just like in the infusion before it achieve the steady state. This one, yeah, fraction achieving steady state, because this is a single dose. Okay, next. Uh, so and if we have to get this city, yeah, you have this one is until here is C max, yeah, but you get the CT at any time, so you have to times again E minus K ini T, yeah, in this one is the T uh, minus T infusion, because the T infusion is 1 hour. So if this one is 2 hours, so from here to here, from here get to here, so it's 1 hour. Yeah. Actually, this will be more clear if you have exercise. Yeah. But last semester I already give you a set of exercise. But if you want, I can give you again. Yeah. So and this one, this example. Yeah. Okay. So concentration time profile single oral dose. Yeah, just now I mentioned oral. So oral, you have got more sophisticated one. Yeah, because oral you have got absorption. This one is the absorption phase. Then only the elimination. Yeah. At any time. So for oral one, you have to have the Ka. Ka is constant for absorption, yeah, and the K is for elimination. Okay, you have to consider the Ka and the K, yeah. Okay. So now steady state IV bolus dose. Yeah. So this one is multiple. So in the bolus dose, multiple dose, it will go up, 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 up until it achieve the steady state. Yeah. Until it achieve the steady state. Okay. The CT equal to yeah. SS means this one, the blue color is when you just give the single dose. The single dose is dose divided by V. That is the blue color. Yeah, if you do blue color. But the red color here, yeah, is the CTSS. Yeah, the CTSS here, this one, yeah, is the D divided by V. Yeah, then you have to um, multiply it. This in the bracket here, it is called accumulation factor, because the drug accumulate until steady state. Yeah, so this one is accumulation factor. Yeah, and this one is anytime, because if I close this, it is the C max. Yeah, C max if I don't have this. Yeah, but if you have CT, so you have to times E min KT. KT is anytime. Yeah. Now, for the pulse or intermittent infusion or pulse infusion is the same. Yeah, intermittent and pulse is the same. So you have the T infusion here, yeah, and then after multiple dose, it achieve the steady state. Okay, now the CT and the steady state, yeah. So if it is here, the single dose, you enough until here only, yeah, the until here enough. Okay, this one is the C max for here. Okay, and then but if here Cmax, yeah, so you have to times the accumulation factor. It's the same, yeah, this accumulation factor and this one, yeah, you see it's the same. Yeah, this one, yeah, 1 divided by 1 minus E min K tau. Yeah, this is accumulation factor. Okay, so here is also the same. Yeah, only thing is that here instead of D dose divide by VD, yeah, this one is IR because it's an infusion. Yeah, it's not the bolus, it's an infusion. Yeah, and divide by clearance, not VD. Yeah, it's a clearance. Okay. Okay, so but you still have to times the accumulation factor. And if you want at any time, yeah, at any time here, the red color, yeah, then you have to add in here E minus K divide by times T minus T infusion. If the T is here, yeah, so this is the T, you have to minus the T infusion because it's only from this time to this time. Yeah, this will be reinforced because in the next coming week, I'm teaching you TDM of theophylline, yeah, and digoxin, I think. Then we will do the calculation. Huh? Okay, so concentration time profile, steady state, oral dose. Yeah, so for oral dose, steady state, yeah. So you have to have, yes, more complex. Yeah, you have to have this one, yeah, the city CSS peak and CSS average. Okay, and then CTSS. So the whole total dose is like this. Yeah, so this one I think this should be a bit here. Yeah, later I adjust lah. Yeah, the this one must be a bit here to here. So as a summary is this, yeah, so this one is CSS average, yeah, and oral you have to, so this one is IV, this one oral, you have to find, you have, because oral you have F, yeah, bioavailability, and S, yeah, and because oral is not infusion rate, yeah, there is no infusion rate, yeah, so it is a dose divided by tau. What is dose divided by tau? It's the same, yeah. The dosing rate. Okay, so for example, the dose is 300, yeah, divided by tau. Tau is 8 hours. So 300 divided by 8 hours, yeah, is the same how with the infusion rate actually, yeah. And then the IV bolus is this one. The red color is what we call accumulation factor, yeah. And this one is yeah, for oral. Okay. Now for phenytoin is a bit different. Phenytoin, yeah, because phenytoin follow the non-linear, yeah. So you have the VM, yeah, CSS divided by KM plus, yeah. Okay, so VM just now I already explained to you, yeah. And the loading dose, okay, so you just target the dose C times V, yeah. Dose. So let's say you want 20 milligram per liter. So the 20 milligram times VD, VD is about 0.65 liter per kg. Yeah, divide by the salt form. The salt form is 0.92 because normally phenytoin is in phenytoin sodium. Yeah, and but in the blood it is on the in the form of phenytoin. Yeah, so if the drug, the tablet is phenytoin sodium, so you have to convert from phenytoin sodium to phenytoin, yeah, by dividing 0.62 if you want to convert back, yeah, from phenytoin to phenytoin sodium, yeah. So you have to divide by 0.62, okay. So drug already present, so meaning that you already have the drug, but it's not enough, so you want to top up the drug, so your target concentration divide minus the measured concentration. Yeah, let's say you measured 10, so it's not enough, you want 15, so your 15 minus 10, yeah. Top up dose, we call it top up dose. Yeah, maintenance dose, aim lower, 8 to 12, okay. All right. Okay, now for phenytoin, the important is the protein binding because phenytoin is 90% bound in with albumin. Yeah, in hypoalbuminemia, so we need to calculate the corrected value. Yeah, corrected value is the concentration observed divided by 0.9 times the albumin divided by 44 plus 0.1. Yeah, because this from weight is 0.9 because it's 90%, yeah, and the 44 is the average albumin, normal albumin range, yeah. For renal failure, because in renal failure you have uremic toxin, yeah, uremic toxin, urea, and some other substances. So because urea will also compete with phenytoin in binding the albumin, so again it will decrease the albumin binding, yeah, to 0.48. Okay. So for assay of for albumin, okay, new target range is 32 to 45. Yeah. All right. So in that case, if you have 32 to 45, it is not 44 here. Yeah, it should be 39 because from 32 to 45, the midline is 39. Yeah, but people are still not sure whether you should use 39 or you should use 44 because earlier it is before this the albumin is 35 to 50, yeah, 35 to 50, so 44 is the middle of 35 to 50, understand? So you
Yeah.
can use RB so the plot as well, yeah, this one you have to practice lah. If you just see like this, it's a bit difficult, yeah. Because you want to know the VM and KM. KM is the this one, yeah, and then the target concentration. You have done this in the undergraduate, right? finish. Yeah. So this is the last slide. You want me um, to explain to you this slide, the last slide?
Yes, sir.
Yeah. Okay. Yeah. So this is this slide. Yeah. Actually, this graph, yeah, is standard graph for phenytoin. Yeah. And what is all this like the web thing? Yeah. Yeah. So this is kind of probability. Yeah. Where it is come from, the probability. Yeah. So what we do is convert dosage into milligram per kg per day. Yeah. So let's say the new dose. Yeah. Um, the dose. Now here in this y-axis, if the dose rate, yeah, milligram per kg per day. Okay. Let's say we have the dose of this. This is the yellow, the red one is before, yeah. So you have the dose here, 4 milligram per kg per day. After you calculate, yeah, then you put here 4. Okay. Then this one is the CPSS. When we do the concentration, you get 4 milligram per liter. Yeah, so you put 4. So 4 and 4. It just happened to be 4 and 4 lah, but it can be different, yeah, different value. So then you connect this, yeah, with ruler. Then you get into here, right? Get into here and here. Yeah. So because the inner circle is the 95%, 0.5. Yeah. 95 95% is what do you call this, 95% confidence, yeah, here. Okay, it will be around here. Yeah. So your when it hit here, then you have to measure the millimeter here, measure using the ruler the millimeter, and get the half of this, yeah, the half. Then you put a point here, then you use the ruler, yeah, to make a straight line and hit the x and hit the y. So the x here, that is the km. Yeah, and from this picture the km is less than 4. Yeah, probably if this is 2, yeah, this is 3.8 lah, like that. Yeah, 3.88, yeah, milligram per liter. That is the km. And how about the vm? The vm is here. Yeah, so if this is 7, it's probably 7.8 or so. Yeah, 7 and maybe 7.5, 7.6. Yeah, 7.6 or 7.7, like that here. Yeah. And then you have per kg per day, so you know the patient body weight. Yeah, so you can calculate the Vmax. Yeah. So now what about the new dose? So the new dose, you have got this dot already. Yeah. And you have the target concentration. If you target concentration 12, yeah, then you have the dot here and you have the dot here. Yeah, here the dot. Then you connect this using the ruler, connect it. Yeah, then you hit this, you hit here. Yeah, and here is your new dose. Okay, your new dose. Here is your new dose. So if it is 5, this one 6, so that one will be maybe 5 point, this one 5.5, 5.7 lah. Yeah, 5.7 per kg per day. Yeah, so you times the body weight. Understand or not, this one? Actually, you don't need to use this also, okay lah. Yeah, but this is good when you have only one set of data. Yeah, one set of data means one concentration and one dose. Okay, then you can use this. Otherwise, you can always use the population data and go into this formula. Yeah, this formula. Yeah, you can always use this formula. Nah, where's the formula again? Yeah? Nah, this formula. Yeah, you can always use this formula. If you have two data, yeah, is better. If you have one data, then each one of it, like the Vmax and the Km, yeah, yeah, like the Km, maybe you have to use the population data. Yeah.
Kita lo lemon.
Why is that? Huh? Okay. So any question? Now it's almost 6 already. Or probably 6
The
already.
next cases, can we go like with the case and then we do the calculation there and there? So it sounds a little complicated with just so much of theories.
Yeah. So so the next one I think is, if not mistaken, yeah, TDM for theophylline. So I'll give you the exercise first. I'll give you the case, yeah, and you all calculate first. Then we can sort of uh, discuss from there. Okay.
Okay.
Okay. I'll give you this slide after I amend the bahasa one just now. This slide got one or two slide with bahasa. I amend it first. Yeah.